Professor Kenneth has, to his credit, over 150 scientific publications, more than 120 conference papers and proceedings, 3 books, a number of monographs, and a lot of scholarly books that he has produced in the last few years. He has several technical papers, several scientific exhibition posters, workshop consultancies, including a WHO, UNDP, UNESCO, FCT, Science and Tech, and he has been a consultant to many national and international organizations. Prof, you have the floor, please.
All right, thank you. Maybe can I share my screen?
Yes, you should be able to share your screen.
Okay, so let's yeah. Just give me a moment, let's see. Sharing. Did you give me the sharing rights? Hello, Doc. Did you give me the? Did you allow me to share? Yeah, I think
we can see your screen, sir.
We can see your screen, but it's showing Zoom. Maybe you need to click your presentation.
Yeah, that's right. Let me see. Can you see my screen from there now?
Yes, we can see your screen, but it's not showing your presentation.
Sure.
An alternative is we can share your presentation from our secretariat. The secretariat can do that for you, if that would be okay.
All right, please do that. Let's see. So because I don't think my screen is showing Zoom here.
So secretariat, please share Prof's screen.
I don't know what's going on. Were you able to find my presentation?
Yes, we're working. Yes, fantastic.
Okay, great. Okay, I think the members of the GET have already established a protocol. I just hope that you're able to hear me very well. If you don't hear me, please just indicate so that perhaps I should be able to increase my volume.
Yeah, we can hear you loud and clear, Prof.
Perfect. So I'd like to first and foremost thank you and your group for the initiative to be able to extend this invitation to me to share thoughts on this very important topic. I think, like you've rightly introduced in your preamble, this is a very, very important topic. And very rarely do we have presentations or scientific talks that begin with a conclusion and recommendation. This is just one of them. I'm going to rather begin with a conclusion and a recommendation, which is very, very, very funny. My conclusion is that indigenous knowledge really can complement modern healthcare systems in addressing emerging infectious diseases on the continent. It has done that several years ago. It is doing that now, and it will continue to do so. And so my recommendation, starting with, is that all we need to do that we are not doing is to, I'm referring to our scientific community, to key in like we are keying in today, to have a better scientific and methodic understanding of how indigenous knowledge is complementing. And it's not even saying can complement, it's already complementing. Perhaps how do we optimize this complementarity? I think that's where we begin this lecture. Next slide, please. Next slide. This is just to give credit to the organizers. Next slide, thank you. So we basically, what I would like for us to understand, there are a couple of slides here, but there are just a few that perhaps I would delve on very, very strongly because of the implication and because of the point of emphasis that I'd like us to carry today. One of the things we're going to learn here is we need to revisit the concept of emerging, and I will add re-emerging infectious diseases within the global context, while of course paying attention to Africa. I would like to share some thoughts as we navigate through this presentation, some thoughts on tropical infectiology, which is something I've spent more than 20 years looking at. And of course, the marriage of anthropology and infectiology. That's anthropology and infectious diseases, because we cannot talk about indigenous knowledge without understanding comprehensively the anthropology of Africa, the ethnography of Africa. This is very key. And I like to say this because I think in the preamble, the coordinator talked about how this GET started within the years of Ebola. And I like to say that the name Ebola is not a name in virology. Ebola is a traditional name within the river Zaire in Congo. Very, very important. It's a traditional name. And what does it mean? A mysterious disease that was really killing people. So the people named that mysterious disease Ebola. Ebola is in the family of Filiviridae in virology. But now we are calling Ebola, which is a traditional name. That's indigenous knowledge. That's indigenous knowledge of the people of Zaire in Congo, which was not used in traditional taxonomy, vis-a-vis modern taxonomy of diseases. What are the implications of this for disease control, understanding as well? So we're also going to look at the positive and negative traditional knowledge on disease spread and control in review. Just some highlights there. We're also going to look at the African and Nigerian indigenous knowledge, medicinal plants and herbal medicine in Nigeria with relevance to primary health care. And how do we redefine medicinal plants and herbal medicine within our healthcare ecology? Next slide, please. These are the things we remember as I navigate through my presentation. Keep this in perspective. Now, indigenous knowledge integration to our primary health care. And this already, like I said, is answering the question, how do we complement? Complementarity would begin in our primary health care sector. What and where are we right now in terms of this integration? We'd have to get reflections on that. And I would give the example of the African healthcare architecture of Ghana and Nigeria, how far they have gone in this journey, and then the strategies on how to integrate them in primary healthcare. Next slide. So while we are reflecting on this, the next slide, please. While we're reflecting on this, why are we talking about utilizing indigenous knowledge in control of infectious diseases? What are infectious diseases? Without wasting time to define infectious diseases, I want us to look at the examples here, and I call it a flashback. HIV and AIDS, very familiar across Africa, malaria, familiar across Africa, tuberculosis. And of course, when we say emerging, we know these diseases are in existence, but then we have new strains of these very diseases, like old wine, adding new wine to an old wine skin. So we have emerging strains of multi-drug resistant tuberculosis, multi-drug resistant malaria, multi-drug resistant HIV, and all that. So these are emerging within the population of sub-Saharan Africa. Malaria kills, so we know what, all talk about malaria for the past 2-3 decades. But then we have artemisinin-resistant malaria, resistance that is emerging. And these are different biotypes. So these are all emerging infectious diseases. So statistics are really abound. If you go on the internet and journals. But the question is, has the situation improved? Next slide. So I can just keep that in perspective. So along the line, you know why indigenous knowledge is very relevant. Next slide. So look at that picture. I brought this picture to see how emerging and re-emerging infectious diseases crisscross the whole world. More than 9 billion people on Earth, and the greatest threat is the emerging and re-emerging infectious diseases. And I will pick one or two. Of course, Ebola comes in. That's the Marburg hemorrhagic fever, Lassa fever, which is sporadic in certain parts of Africa. Of course, we talked about the well-known Ebola that grounded, the entire globe for a moment, and we know the impact, and we are still feeling the impact. So this is just to give a picture. Next slide. Next slide. So in Africa, based on World Bank records, and this is 2001, but then the statistics remain the same. HIV, malaria, TB, measles, all these are abound in sub-Saharan Africa. Next slide, please. So just roll down the slide. And I highlighted this in red. Malaria still stands. HIV, of course, with a lot of research has gone on, advocacy has gone on across the continent. Yes, HIV is declining, but it's still there compared to other continents. So I put that in red, so we know. Diarrhea disease and dysentery are still there. And what are we doing? I put on the title there, disability adjusted life years. So these are really impacting on our ability and our years, of course, and the lifespan of our people. Next slide, please. Next slide. So these statistics, yes, just to give an idea that the problems of infectious disease are still there. The complications itself, not just the epidemiology of this disease, but the complications that are there, and the complex mesh between infectious diseases and non-infectious diseases. So very interesting. Next slide. And of course, now we are even now clamoring and glamoring and getting worried about even neglected disease, because we've paid so much attention to certain diseases, certain infectious diseases. Then, of course, some other diseases have become so much neglected. But the question is, for neglected tropical diseases that we are talking about, is there an indigenous solution? The answer is yes. Next slide. Next slide. And this flashback is just to give you a foretaste of why we are here and why we have to key into indigenous knowledge. And I like to say this, so this is the crux of our presentation right now, and our talk. is what is indigenous knowledge? What is traditional knowledge? Knowledge that is common to a certain cluster of people that the people have been existing with. It's all linked to the anthropology, linked to the culture of the people, linked to the mindset of the people. Now, what is traditional knowledge? Traditional knowledge also would vary from place to place because there are different cultures and there are different set of people. When you look at the history, where they are, geographical location, their history and all that stuff. Now, they have some specific knowledge that is also tied to their existence, tied to their rituals and all that stuff. So the question here is, and I want us to pay attention, is all that glisters really gold? Like Shakespeare would say that in some of his books. Not really all traditional knowledge or indigenous knowledge is good. So I will begin with the harmful traditional knowledge. I would say this is not really something I would like to say here because it's a topic for another day. There's a lot of harmful traditional knowledge that we need to also understand, which predisposes us or the population to zoonotic infectious diseases. And I call that zoonotic infectiology. For instance, there are so many tribes that take rodents as food, and it's a delicacy, and they take that in their traditional rites. For instance, marriage ceremonies and certain traditional occasions, if they are compelled to use rodents in terms of preparing the traditional meals. And of course, rodents are actually vectors for certain diseases. So this is very important for us to be able to review this and not just feel that every traditional knowledge or indigenous knowledge is good. Now, I mentioned the Tiv people in Nigeria, in Benue State. I've taken a study about that. We also have tribes in Southeast Nigeria. And of course, we have tribes in Central Africa, the Bakars, who are very much within the southern part of Cameroon, the Pygmies of Congo. They have certain traditions that are also not very healthy, but then they have that concept that is good, and they use that, and they are also predisposing to emerging infectious disease. I've just captured some pictures there. And if you look on the right, you see a picture of cowrie there. There's traditional knowledge on using cowries for diagnosis of diseases. Yes, maybe bad in providing unscientific results, but in certain circumstances, they also provide results that could be verified through science. But how much have we been able to understand these extemporaneous practices? So it's cause for research. Now, this is interesting. For instance, when we had Ebola, that hit Sierra Leone and Liberia, certain traditional practices that really generated rapid spread of this Ebola, the burial ceremonies, shallow graves, people, being close to corpses and all that. These were traditional practices that were really promoting Ebola transmission. We're aware of that. And of course, tribes that were eating bats, which is actually the vector for the transmission of Ebola. And of course, traditions had that, bats is a delicacy and all that stuff. So these are practices that are indigenous, but then they are harmful. So we need to take care of that. And then we have tribes that, live with snakes, and eat snakes and all that. So these are things that we need to also consider as harmful, as well as to exploit the positive aspect of it. Next slide, please. Next slide. So the harmful traditional practice, just highlight some of them here. I've already mentioned that, and I like to say this. It is through public health around the 1665, the plague in London, that the concept of burying people 6 feet came into existence, and that was because they were trying to prevent transmission of diseases. But then there are practices in certain traditions across Africa where they don't bury corpses 6 feet, and that's also quite risky. And with the need to understudy this by science and then inform them through policies and through capacity building. Next slide. Next slide. And if you look at the picture while I'm moving on the slide there, the picture there, I did a study on one tradition from Cameroon where, they have half-cooked chicken, which is a traditional meal for certain traditional ceremonies. And that particular half-cooked chicken was actually responsible for the spread of Toxoplasma gondii. And that's very risky, but the people were unaware of that. But it's only when we came up with the scientific evidence that they were able to now change that decision. or try to improve on that decision. So not all traditional knowledge is good, but then there is a goodness in it that science must be able to x-ray. Now, let's go to the useful traditional knowledge in curbing infectious diseases. We are all aware that COVID did not hit Africa the way it was anticipated. And we know that at the background, it was due to traditional knowledge, how people were able to cope. And this is very, very important for us to know. Now, we are aware, I'll just give a highlight here. Plants are used in steam bath to quell down pyrexia caused by infections. For example, you have a fever, different fevers, we call them pyrexia of unknown origin. Fevers like malaria, enteric fevers like typhoid and all that. People use steam baths, which is a traditional practice to quell down these high temperatures and try to kind of stabilize these temperatures. And that's a traditional practice. We all saw that during COVID. This takes care of hemo fevers by Plasmodium falciparum, enteric fevers, which are caused by salmonella. And we had people and tradition where they made infusions of Symphopogon citritus, which is called the lemongrass, and they use that to bring down fever. And if you can see on the picture there, you see how food is wrapped in banana leaves, and banana leaves is actually a preservative and maintains the aroma of the food, unlike using aluminum plates and all that stuff. And if you see on the right there, that's a corpse that is preserved using banana leaf, and that is in Plateau State that I found this, the Kuru area in Jos, and it's just like you know, a traditional embalmment of that particular corpse, pending when burial would take place. And we did studies to find out that banana leaf or the plantain leaf has antiseptic activity. That's very interesting knowledge. Of course, the use of garden eggs and wild garden eggs, extracted wood ash, liquid to treat gastric ulcers caused by Helicobacter pylori. These are very useful traditional knowledge that we need to key into, and people have been using it for ages. Next slide, please. Next slide. Of course, some very interesting traditional knowledge that we have been doing a collation of it for over 17 years and above. The use of monkey and bush rodent liver by a certain tribe within Gabon in Central Africa, where they prepare it with palm oil, you know, steam with leaves of Ocimum gratissimum. That is what they call Masepo plant. I think some of you are very familiar with Masepo, to treat yellow fever. And this is very effective. And we took time to be able to understand the ethnographical evolution of such usage. And we came up to realize that, yes, it has seemingly has some, you know, anti-yellow fever activity. The use of tinctures of Cyzisium aromaticum and Allium sativum, as well as Piper guinensis, Ocimum gratissimum, to treat and prevent SARS-CoV-2. This was a widely used concoction during 2020 when COVID was at the peak of the event across sub-Saharan Africa. We were doing some studies for the African Union, and we came across this. So this is traditional knowledge, and it worked very, very well. Next slide, please. Next slide. So again, the story can go on and go on and on. The use of extracts of fluted pumpkin mixed with raw egg and Guinness alcohol to treat resistant typhoid. I mean, some of this traditional knowledge may sound very, you know, so archaic, so frightening, but yet something we need to key in to find out, bring out the experimental evidence of this, the empirical evidence of this. But then the people are using it, they are surviving on it. The use of Garcinia cola, that's what they call beta cola, decoction, put in drinkers to treat H5N1 strains, Gumboro virus disease, Newcastle disease in poultry. This is a very widely practiced traditional practice that has been used in northern Nigeria, in northern Cameroon. I also found that some tribes in Uganda also use this as well. The question is, do we provide the scientific basis for this, or do we dismiss this? And I like to say this, African countries are just barely 60 years above since they got independence. Before the Berlin Conference in the 18th century, African colonies were purely colonial colonies. And that's when Africa was partitioned during that Berlin Conference and League of Nations. And we were actually existing and using traditional knowledge. So next slide, please. So I want us to keep that in perspective, how irrelevant traditional knowledge has been. And that traditional knowledge and indigenous knowledge is actually a signal for drug discovery, a signal for holistic health. But the question is, how have we been able to harness this? And let me say this, the scientists across Africa are the major problems, because the indigenous people of Africa, they're using it. But the scientists, because we are coming from an exotic model of reasoning, that is why we criticize our knowledge without proper search and understanding of this knowledge, to use them as clear hypotheses that must be verified scientifically and then collated and coordinated to come up with what they call a standard operating procedure, a community of practice that we really need to use. And that's where the problem is. That's a major gap. And I like to say this. Why I'm saying it's a signal. Take, for instance, look at the slide in front of you, where Bahama grass, this grass that we have on the football fields, concoctions are used to treat parvoviruses in dogs. That's a very important knowledge to be able to develop, an anti-parvovirus medication, just following the signal of nature where dogs go and eat this. The use of mistatil, this parasitic plant, and Actium lapa, these are all plants that exist in Africa, the concoctions, mixed in soybean oil to treat black spot diseases of cocoa, treat the disease of cocoa, which is also called botrytis and fusarium, from food crops as well. So these are knowledges that are there. People have been using it to survive. The question is, how have we been able to optimize this and use it in our daily practice to improve our status quo? Next slide. Next slide, please. And during our studies, we found out a lot of information, from the rural people, from local people across Africa, because we've been working with almost 49 countries across sub-Saharan Africa. We have that research consortium. And a lot of them were telling us the HIV virus exists in monkey, called SIV, simian immune deficiency virus. But then it doesn't distort their immune system. Why? And why is it that the same virus in humans now causes immune deficiency? Could it be because of the fact that the monkeys are so close to nature and, depend entirely on nature, and that their immune system is so strengthened? These are lessons that we need to learn. Now, the picture in front of you, some communities are using different bananas. Look at the banana. We have these bananas, but we don't know the uses. And they're using that to treat Helicobacter pylori. Just the peel of the banana to treat Helicobacter pylori. And I'm going to show you that it's not just collecting this information. We're able to do verification, valorization, as well as develop some products. Next slide, please. Next slide. And having said this, I will now move to what we have done. With the use of this knowledge, how can we optimize it in modern healthcare to address diseases? Next slide, move on. Next slide. Now, I would say WHO recognizes what? These different types of medicine: traditional medicine, orthodox medicine, and complementary medicine. The Chinese are practicing complementary medicine called Chinese traditional medicine. They have developed it. The Indians have developed the Ayurveda. The Koreans are developing theirs. The Peruvians. What about Africa? Next slide. Is there any progress in Africa where people can now come into African medicine? Because when they talk about African medicine, people start beclouding themselves in some psychological primitivity. And that is because we have not been able to put the science very clear, and we've not been able to capture it and integrate it into our system in such a way that we have an organized and systematized system. That's the problem we have. I was opportune to give a lecture, organized by the then First Lady of Nigeria, Mariam Buhari, in collaboration with the Turkish embassy. And they asked me to give a talk on how indigenous medicines and traditional knowledge can be used in primary health care. And I like to now, submit here very strongly that indigenous knowledge, the first step on how we can use our indigenous knowledge to optimize it, to have a system, is to key it into the primary healthcare system of Africa. Next slide, please. Next slide. And what have we done This is personal. This is our research group now. What we have done personally in effort to see how we can take this and complement it, fitting into the primary healthcare sector, which is built on the orthodox philosophy. How do you build traditional knowledge and traditional medicine and, harmonize it into the orthodox system? This is the 1001 question. So we started first by creating a database, developing at our station. We have a database on plants that treat, bacterial infection. We have a database on traditional knowledge on plants that treat fungal, viral infections, GIT infections, and all that. You can see in front of you. So we created that database at the Phytobiotech Research Foundation. Next slide, please. So we have the database, and there are some people who also have the database. And then while we're doing that, we discover that there are plants in Africa built on traditional knowledge that the Western society have actually extracted, and they're using it to produce single molecules and trying to take that knowledge, traditional knowledge and indigenous knowledge of Africa, and to produce a single allopathic molecule for servicing of orthodox medicine. And that's wrong. And we submitted this is wrong. Now, there are two strings. They needed to understand how these plants can further be used as that traditional medicine without changing its morphology, without changing its competition, and without trying to isolate compounds, and then just to be able to generate quality and proof of concept and use it as traditional medicine. But then on the other string of it, you can pick an active molecule and produce a single molecule drug to service the orthodox system. This is where Africans need to draw the line. We need to draw the line. And that is where I give credit to Ghana, who have been doing some work to be able to integrate this into their healthcare system. Amidst Hospital in Accra, and I saw this in practice. And I give credit to Nigeria, where they created the Department for Traditional Complementary and Alternative Medicine, TCAM department, under the Federal Ministry of Health, where they are now trying to see how they can integrate this system. Now, here on the slide in front of you, these are African plants where the active molecules were taken out and they were now trying to produce a single drug. Next slide, please. So we need to be very careful about this. Now, this is the practice. This is the practice sui generis for African traditional knowledge and traditional medicine. The two are becoming inseparable. Traditional knowledge and traditional knowledge, they're inseparable because the knowledge of how these plants are used to treat diseases was not gotten from a medical school. It was not gotten from a faculty of health sciences. It was an innate knowledge that came from the intertwined nature of nature itself. And that is a dogma. We call this dogmatic medicine. Some people even call it prophetic medicine. And this is important. We cannot beat prophetic medicine. We cannot beat dogmatic medicine. All we need to do is to understand how we can use it. Next slide, please. Next slide. Next slide. Now, this is the traditional pharmacy for Africa. Now, what is our own pharmacy? The orthodox pharmacy is what we have widespread across cities today, across the continent, where you have, amatem, chlorophenicol, ciprofloxacin. That is the orthodox pharmacy. What you're seeing here is a traditional pharmacy. They've been able to see how they can bottle their concoctions and all that. Now, the question is, how do we bring the marriage of this traditional pharmacy and orthodox pharmacy to cohabit and coexist in one space? We haven't done that yet. Next slide, please. Next slide. So I have started by saying that the complementarity must begin with the primary care health sector. What is primary health care? Next slide. Not secondary health, not tertiary for now, but let's begin with primary. Primary health care is the first point of treatment. That's what you find in local government areas where you have a fever, you have a malaria, whatever, you first rush to a primary health care. Next slide, please. Next slide. And of course, the primary health care is as old as human today, because that is actually coming from the Armor Attack Declaration of 1988, where we also talked about the health for all by the year 2000, which we never achieved because of the fact that the health for all by the year 2000 would have been achieved if we had complemented the African indigenous knowledge, particularly for Africa. We cannot use the same principle of healthcare delivery for Africa. We cannot adopt the European system entirely in Africa. It's not going to work. It's not working. It's not going to work. It would not work. Next slide, please. Next slide. So next slide, move to next slide. So I've talked about the Amata, where we must look at health in totality. Yes, primary healthcare. Next slide. Move on to the next slide. Next slide. So, you know, our work has actually been informed by what happened in COVID-19. During COVID-19, we were really embarrassed with the challenges. But then, of course, Africa survived, and it was because of indigenous knowledge. Next slide, please. So we listed, you know, plants and traditional knowledge that were, you know, addressing COVID. That's what I show on the slide in front of you. We had turmeric, ginger, and all that stuff. Next slide. And we found a lot of publications in these. But then now people were using it. But we failed to now harness this into medications that we should have had centers for treating COVID-19 using traditional knowledge. But then, of course, the Western system actually superseded what we should have had here because, well, the whole world focused on vaccine, but then the traditional knowledge was relegated. But then forgetting to know that below, you know, at the bottom in our closet, many people survived using indigenous knowledge to cope with COVID-19. Next slide, please. Just roll down the slide. I will tell you where I can focus. So these are plants that were used, moringa, cinchona, and all that. This is moringa. Next slide. A lot of people use moringa. Just go back to the previous slide. And we found out scientifically that moringa, 7 times vitamin C of orange, 4 times vitamin A of carrot, 4 times the calcium of milk, 3 times the potassium of banana, 2 times the protein of yogurt, just the plant itself. Next slide, please. Roll down. Now, yes, so our work, basically, I'd like to now spend the last few minutes to talk about what we as scientists have done in this integration. Is it just picking the indigenous knowledge? What we have done is to document our indigenous knowledge, and which we scientists, we really have to sit down and document. Look at, just take, for instance, Nigeria. What are the indigenous knowledge and traditional knowledge of controlling infectious diseases, and even the names of these infectious diseases in Yoruba culture, in Igbo culture, in the Hausa Fulani culture? Do we have that documented? Even at TCAM department under the Ministry of Health, no, it wasn't documented. Now, even if you go to many tribes across Africa, where we speak more than 250 different dialects, what is the name of, for example, salmonella, typhoid, in our different dialects? How do we control it? Before independence, when people were existing and they were treating typhoid traditionally, how were they calling it? What was the taxonomy? What was the diagnosis? These are things that are very important for us today to understand what has happened in millennia and to key it into the current day community of practice. Next slide. Next slide. So in this next slide, you see what we have done in our work. After doing our databases, we've been able to screen these plants in front of you. See, this is spinach, which is a common plant, that vegetable that we eat. We've been able to screen it, look at the macro elements, but how do we screen it? We follow traditional knowledge, macro elements and micro elements and all that. And we've been able to produce products which we felt that if we understand the phytochemistry, if we understand the bioactive principle in it, and then if we're able to, without changing, without isolating single molecules, but if we formulate now, knowing the active principle, then we can have a product, what we call a nutraceutical or a nutritional supplement, which we can now integrate into the primary healthcare pharmacy. And that's exactly what we've been able to do. And that was what gave the Mark Bopelette Gold Medal for this work, which we did here in Nigeria and across other countries in Africa. So you can see the plan there. Next slide, please. Next slide, please. So we have screened all this, screened local mushrooms, listen to people, how they use mushrooms. This one, Stomatomices robusta, which we found a tribe in Bauchi State using this to treat measles. Very interesting. And so we worked on it. Next slide, please. So this is our work. So we are screening these plants, and we discovered that Nigeria has more than 80,000 medicinal plants in their pharmacopoeia. Next slide, please. Next slide. We screened this for anti-salmonella, anti-diarrhea, and geared towards producing a classical product for primary healthcare. Next slide, please. Next slide. Next slide. And now this is the extraction. So for us to integrate with science, we must be able to do this to show that, because Western medicine will tell you we need proof of concept. So this is the way we were deriving a proof of concept. Next slide, please. Next slide. Great. And after doing that, we now decided to say, okay, let's produce our tablets. So this is our word. We are producing tablets that we are not synthesizing. We are not changing the chemical formula, but we are producing the tablets. And the target here is what? Nutraceuticals. But we were using this to potentiate already existing medications. So we take, for example, what you see in front of us here, that is bitter cola, Garcinia cola, as well as Moringa oleifera and ginger. And we use this to potentiate chloramphenicol, azithromycin, and ciprofloxacin. And that was a groundbreaking work that we did, but it was built on the inspiration of traditional knowledge. It was built on the pillar of indigenous knowledge. Next slide, please. And then here we are. So we developed these products. These are the products. We developed a product here, for treating HIV. And now we took it to regulation. So NAFDAC looked at our methodology to see that the toxicology is right, the efficacy is right, and NAFDAC gave an approval. So now these are the medications that are bottled there in front of you. Next slide, please. Next slide. And now this is the approval from NAFDAC. We're doing this built on traditional knowledge because we want to integrate it into primary health care. That's why we have to follow this regulation. So the first step is to get the science correct, get the valorization, and now you can integrate it easily for doctors and medical personnel to do prescription. So we presented this and we worked with the African Union also. This is actually for hepatitis. Next slide. Next slide. Here we go. And if you see number 3, we found this compound called, mercantinquinol, 1-methyl ester from one of the plants, and we published it in Journal of Natural Communication in 2016. That's the publication there. But we're doing this, giving to Caesar what is Caesar, and we give to God what is God. Caesar is the West. In this case, Caesar is the Western medicine. So we have to now tell them, well, the concoction you see over there, we are not going to produce a single molecule like you have with paracetamol, but we are going to produce our nutraceutical. But the active ingredient is what? Mercantin C, mercantin Q, and of course, mercantinquinol 1-methyl ester, and perotectin E, just so that they know that we understand the science. We know we do that valorization as well. Next slide. And the next slide takes us to what? The mechanism of action. So we did this for HIV. Take the next slide. The mechanism of action, we studied it. And we realized that the active ingredients are actually anti-cytokine storm. Next slide, next slide. Just roll the slides. So we looked at the methods, the mechanism of action. Next slide, next slide. Good, we did a clinical trial now. So for us to put it in primary healthcare, traditional knowledge, we must be able to do a guided clinical trial. Sorry, I use the word guided very cautiously. The clinical trials we're doing for food that we have been using based on traditional knowledge must not be, the clinical trial wouldn't be the same like doing for single molecules. No. So this is very carefully said. This is another topic for another day. Next slide, please. So we did this and look at the benefit, and we're seeing how this was actually improving HIV/AIDS patients for that, and we published a book on that. Next slide, please. And as I'm rounding up now, next slide. We started to go out now. We did a Lancet publication on this. We've set up an institute for phytomedicine and physiatry, which is built on traditional knowledge and indigenous knowledge to harness it in a proper way. So what we are lacking is what? The methodology of how to harness traditional knowledge and the integrating it into our primary healthcare. And that's what I've shown you there. Next slide. Next slide. Just hold down the slides. So we published all this. Yes, next slide. NAFDAC gave approval. Next slide. Next slide for all the products we have. Next one. Now, we now said, well, this is the way you can integrate it because now you can prescribe it now. Next slide. Next slide. And now we're able to identify the potential barriers and we take care of them. Next slide. Next slide. Now we went back to the community where we got the indigenous knowledge and we gave it back to the king. This is one of our pilot projects in Cameroon, where we went to the king and look at the medications in front of the king. For the king to say, yeah, we're blessing it. This is your knowledge that we got from you. We've been able to valorize it. We have NAFDAC approval. We're using it in the primary healthcare sector right now. And the king now is now blessing it. And now it has become a community of practice for the people. That is the way to go. Next slide. Next slide. So we have a pilot project where they're using it. More than 250,000 people now are as a community using it. So we call it the Ebanicom project. Next slide, please. Next slide. So this is a case study. So we're using it in this community in Cameroon. The next is a community in Anambra State, Anam community, where we are also having this model being practiced at the community level. Next slide. Next slide. So that's case study 2. So these are the elements of how we need to integrate it. Next slide. Next slide. Now, this is the research output. This is a summary poster that tells us the research output, which I've already highlighted. Next slide. And now we are now commercializing it. We now, the slide in front of you, a pharmaceutical company has come to consult us and say, we want to produce the product. Next slide. Next slide. So next slide. So these are just some thoughts on how we can integrate it. Next slide. Next slide. All right. Next slide. That's fine. So in conclusion here, I would say that we don't, for us to have indigenous knowledge integrated into our primary health care to address emerging infectious diseases, we don't need a vertical disease control approach. So that's why I've canceled it there. You know, it's like a boxer on the ring. Whatever you see, you box it, you know, you blow it off there, wrestler. That's not the kind of approach we're using, that we have to control infectious diseases. We need an integrated approach that incorporates both modern, modern orthodox medicine as well as traditional knowledge as well in one space. So we need that particular integration. And I've said that can only work effectively as we have demonstrated in our pilot communities at the primary healthcare level at that moment. And I'd like to, this is my team, which was set up by the African Union Scientific Research and Innovation Council, called ASRIC. I'm chairing this team. We call it the Afrocentric Working Group, and basically to harness the African indigenous knowledge and traditional knowledge, create a portfolio of community of practice and standard operating procedure to operate in the primary healthcare sector of Africa. And so I give credit to them. They worked very carefully with me, and I'm coordinating this particular team. And it covers the whole of Africa. So it covers East Africa, West Africa, North, Central, and Southern Africa. Next slide. So yeah, go to the next slide. So we've made some series of publications on that. We've made some series of media, telling our scientists what kind of clinical trials we need to carry out. It cannot be the same clinical trials. And of course, we also inform NAFDAC the measures and the evaluation approaches that they use for orthodox cannot be applied to traditional. These are two different systems. Last slide, please. I think would probably want to say that we have a company that we have set up, which is inspired by traditional knowledge, called STK Biotech. It's in Owerri in the Southeast. And we have 6 licensed products built on traditional knowledge, and that they are now in the pharmacy and also being used at primary healthcare sector. That is great. We form an institute called Institute of Biophytomedicine and Physiatry, which is registered for training and provision of certificates, and also to support indigenous medicine practitioners, because some of them haven't gone to school, but they're inspired with this knowledge. But we need to be able to provide quality control for them, quality assurance for them, and all that. So that's that institute is really for that purpose, registered by the Nigerian government as well. Last slide, I will thank all of you for your patience. And like I said, these are some of the references that we have generated a lot of work published on this. You can go online to read about this. Like I said, I started by saying, in conclusion, that indigenous medicine and indigenous knowledge has been in existence before you and I here, and even before the coming of the Western society in Africa. It will be there, it will continue to be there, and after us, it will be there. So we need to take advantage and start to key in to all the things I've talked about. I've simply shown you what it is and what in our own little way, our own contributions, what we've been able to do. So, Mr. Chair, thank you very much. And I also like to thank our co-speakers, even before they speak. Thank you very much.
Thank you very much, Prof, for this very insightful, elaborate presentation. Let me start by saying a very big thank you to you and members of your team for the great work you're doing in Africa. You've shown clearly that indigenous knowledge and indigenous medicine can effectively complement the orthodox medicine that we're used to. And you've proven it beyond reasonable doubt with clinical trials, with different, with phytochemical analysis, even to the level of patenting some drugs. Like people used to say, until you start finding or you start getting homemade solutions to challenges, then you continue to be at the mercy of others. And like you said, other countries like China, India, they've been able to develop their own indigenous knowledge to address and solve their problems. And thank God we have people like you too that you're maximizing the knowledge and the natural abilities within the continent of Africa, as the trees, the plants, and thousands of medicinal plants that we have within the continent to find indigenous solutions to the challenges we're having in the area of health on this continent. Thank you very much, and congratulations to the great work you're doing. I'm sure your presentations will generate a whole lot of questions, and I was going through the question and answer section, and I was seeing people asking different questions about the drugs, about where they can get it, and so many questions will come out from your presentation. Number one, I want to say that we are going to share with the permission of Prof, we are going to share his presentations with the participants so that they can, because it's a 68-page well-documented research. I'm sure this research that Prof presented in less than 1 hour may be a research of almost 20 years of continuous hard work and activity. So we'll share, with his permission, we're going to share the slides with our participants. And with his permission too, I'm sure a lot of our participants will want to get to meet Prof and ask 1 or 2 questions. We can share his email with them if he agrees, and so that they can continue this discussion after this webinar. A whole lot of information have been shared by Prof. And if we spend 5 hours here, I'm sure we will not be able to effectively digest the presentation of Prof. But at least you've given us an intro, and we can start running from what you said. And also, I hope this will be a platform for collaboration between Prof and GET and many other organizations that are represented on this platform as we speak. So for those that have questions, again, let me repeat, put your questions on the question and answer section. We're going to take your questions after the presentation, and we're going to give opportunity to 1 or 2 speakers to contribute after the presentation from the speakers. Without wasting time, I go straight to our second speaker. I'll read his bio, and I'll hand over the floor to him. Our second speaker is Dr. Jegede Obafemi. He's a senior research fellow, Institute of African Studies, University of Ibadan, Nigeria. Dr. Jegede is a traditional African medicine practitioner who is also a senior research fellow at the Institute of African Studies, University of Ibadan in Nigeria. In the Institute, he coordinates the unit Traditional African Medicine and Belief Systems. Dr. Jegede has extensive link with the traditional healers community in Nigeria, and is a 2-term laureate of the Council of the Department of Social Science Research in Africa, that's CODESTRA. He also won the Comparative Research Network, CRN, of CODESTRA on strategies for the treatment of mental illness in Nigeria and Kenya. He's also a fellow of African Humanity Program of American Council of Learned Society. Dr. Jegede is also a winner of National Research Fund of Tertiary Trust Fund, that's TED Fund. He has written many books and has been involved in many research in different parts of the world. Dr. Jegede, thank you for joining us today. I hand over the floor to you, please.
Yeah, thank you very much. I'd like to share, okay. Can somebody help me to share the project, the presentation?
The presentation, okay. Please,
I'd earlier sent it, and I think it has been.
Yes, Secretariat will share your presentation, Doc.
So please do. I'm waiting.
Yes.
Oh my God. Hello?
1 minute, Doc. The Secretariat will share your presentation very soon.
Okay. I'm waiting.
Secretariat will waiting for you.
Just a minute, it's processing.
Any progress? Hello? Hello?
Doc, give us a minute. I think the Secretariat is working on it.
Okay, sir.
Yes.
Okay.
Can you see the screen now?
I'm waiting. I can't find out. Yeah, no. Okay, wait for me. No. How do I? Okay.
So the screen is on now, Doc.
Yeah, I've seen screen, yeah.
Okay.
Yeah, thank you. Yes. Thank you. Can we please the next line?
Next slide, please.
I'm just seeing the topic. Okay. Thank you very much for this special privilege to present my work, my paper on case study of indigenous knowledge, success, and lessons learned. Recently, indigenous knowledge has come into the fore of intellectual discourse. It has become very, very important. Like the Prophet said, that it has been there, it is there, it will always be there. It was as if it will go into total extinction. Because at a point, it became illegal to engage in anything that is indigenous. And because whatever is indigenous itself is so resilient and is in us, part and parcel of our destiny, it is coming up again, is becoming the gist, the end thing. We have not realized, and though we experience, it's very, very, paradoxical that we have experience, yet we do not realize. For example, most of us, at least in Africa and Nigeria, what really sustains us, are those things from indigenous knowledge. I give an example of agriculture. If you look at yam, cassava, okra, and everything that comes from the farm to us to eat, they are all produced by indigenous knowledge. I can assure you that the food we eat, not very many of them were produced through mechanized farming. We are sustained and we survive by farmers who use hoes, cutlasses, sickle, and trap, even hunters. We are sustained by them. For example, if you could say that today, let all the farmers begin to use caterpillar, we will remain perpetually in hunger. Till tomorrow, it is the farmer that use all these things that are indigenous, that are sustaining us. Then the area of food. The food we eat are also produced using indigenous method, in spite of how much agitations and advocacy for mechanized farming, mechanized way of production of food and stuff. Yet most of the food we eat are produced using indigenous knowledge. Even those that are mechanized also use indigenous knowledge to do mechanical whatever. For example, the gari, it is fried gari that we eat. Though there are machines that now produce gari, but most of the gari that we eat today are fried. Elubo, you see elubo that is a plantain flour. I mean, that is a yam flour. You see that most of the time, most of the yam flour that we eat are spread inside the sun outside. If you are traveling to places like a Betty, like a Kwara State, you will see people who are spreading cassava flour on the mountain, on hills, and these are the flowers that come to market and even shops for us to eat. So also maize, so also corn porridge, for example. I mean, even maize and all kinds of food that we eat, they are all products of indigenous knowledge. And so we have not escaped, and we cannot escape. Incidentally, people now begin to prefer that which comes from this kind of knowledge system than that which comes from mechanized knowledge system. And they are very correct. The ridges that are made with machine and the ones that are made with oil, the food that comes from all these ridges do not produce the same nutrient. I say it unequivocally because I've tried mechanized farming. I've also tried, indigenous, farming system. And I've seen products from all these two methods. And, people all over the world are now asking for that which emanates from an indigenous knowledge system. People want to know, do you have fertilizer? Do you have chemical in all these things? If it does, they don't want it. Everybody wants to deal with that, which is natural, which is indigenous, which is native. That is what is going on now. So if you remove it in indigenous knowledge, in spite of the overwhelming force of Western modern contemporary knowledge, if you remove indigenous knowledge, we will cease to survive. The next line. The next line, please. Okay. Things are moving. The Alma Ata Declaration, as a prof, rightly mentioned, in 1978, opened gateway for traditional medicine to find its food in the earth system globally. And that is one of the most important aspects of important intervention to traditional medicine and the development of Africa or global development. You see, like Prof mentioned, I will keep referring to Prof presentation, because he said Africa refused to, or even refuses to annex the import of this declaration. But China quickly annexed it. And China is what it is today because of its indigenous knowledge. I've always attributed whatever development that China is said to have today to its indigenous knowledge. I don't know why Africa is still sleeping. Why we have refused to, when WHO, the mafia, the mega health organization in the world, when they have made the declaration, why is Africa so lethargic at it? Why are we not taking advantage of this? I think that's very, very, very important. Incidentally, and I'm sure Prof knows this, that more than 70% of earth-seeking people, seek earth using traditional medicine. And it means that the issue of acceptability is no longer questionable. And people are now consciously escaping accumulation of toxin. They are saying no to toxic medicine, to this acidic medicine. They are rejecting it. Everybody is looking forward to nature. So this is a great so during the COVID-19 saga, nobody is asking why is it that traditional medicine was the in thing all over the world. Even WHO was not talking of something else. Everybody was looking up to traditional medicine, and you all know about Madagascar saga. How Madagascar came up with a recipe that became so popular that even I read that America had to order so much. So the traditional medicine and COVID-19, issue supposed to be set aside and to be an avenue to establish the validity and value of a traditional medicine in health management. And we're not, I mean, I wish that we also ask ourselves, why did COVID-19 do so much havoc in Europe, America, and Asia, including Australia, and not much in Africa? Not much in Africa. Why? It is the same traditional knowledge, indigenous knowledge that has been helping us. Why is it that it wreaked so much havoc in Europe? It is because they lack indigenous knowledge. If they had indigenous knowledge, they could have annexed it. People died in thousands in Germany, in Italy, in Europe, in America. But in Africa, it didn't happen as much. And we all hinge on our indigenous knowledge. And we actually slept off. Because COVID-19 was not killing us, we slept off. Instead of us to took the advantage to unleash, what Africa has to offer to the world, what Africa has to offer to humanity. We're not making any point out of that. That COVID-19 issue is supposed to, push Africa into the global space and let the world know that we have power. We have what we can use to rescue humanity. And Europe didn't care. Europe is not asking Africa, how did you do it? They're not asking. They cover it up as if it's not something significant. And I've always argued, when you talk about health globally, about development globally, the very strongest indices that show a developed person is the level of health. Health is the strongest indices of development. It cannot be good road, good NEPA, good. No, it is how healthy people are. That is what shows how developed they are. And I say it unequivocally, Africa is the most healthy people on earth. The African people are the most healthy people on earth. What is it that has helped them? It is the same indigenous medicine, indigenous knowledge. Prof, go venture into this space, and you can see in few years, how many discoveries, he has made or they have made. Imagine if he's using Western epistemology or Western, methods of, scientific investigation. I mean, strictly, he will never have arrived at this. I know in UIA that I teach in the Faculty of Pharmacy for I don't know how many years, more than 10, 15 years now. They have been working on what do you call it, on Momotica Tirantia, aging. Till now, they have not discovered the value. They say they are looking for active constituent, and they are still looking for it till tomorrow. Aging that have been used by our forefathers for more than, I don't know, hundreds of years. They are still looking for the active ingredient in it till today. If you are using that method, we will use 100 years to work on only 2 or 3 plants when we have over 300,000 plants in Africa. The next line, please. The next line, the next slide. Yeah. So there is an ongoing revolution. There's a revolution going on, at least, where people are now developing interest in traditional medicine. There are now schools where people can learn and become, professional in traditional medicine. Well, I've argued that one of the major issues is the question of professionalism. Medical doctors have, our medicine itself has professionalized its practice so much, but traditional medicine is not able to professionalize its practice adequately. I think it's because of lack of adequate training. And so there is, a lot of trainings are going on all over the place. And the colleges that are established, College of Medicine, now have the kind of department or subject teaching traditional medicine. In fact, I learned that some of these universities, Faculty of Medicine, now have traditional medicine in their curriculum. But that's not enough. That's not at all enough. Then, for me, I engage in a research with a UCH. Though I'm not a medical doctor, I am a Babalawo by interest. And I don't do science like a prof is doing. I do indigenous knowledge. I use what I call ethnography, phenomenology. I'm much more Afrocentric. I don't go to laboratory. My laboratory exists in the street, which I call community. My laboratory is in the street, is with the people. It's not in a room. It's not in any space except, in the open room. That is where my laboratory is. And so I discover based on encounters. I discover based on experience. However, I still work with UCH. That's a research sponsored by National Institute for Health Research in London. And they are asking us to see the possibility of establishing a well-coordinated, collaboration between traditional medical people who take care of mental illness and psychiatrists. And we are doing a great job because it's a well-sponsored project. And we are making, very remarkable progress because, we are concerned more about the referral pathways. We are in those who are treating mentally ill people in traditional medicine homes. We will refer people to UCH. We are areas where the traditional people are not able to handle. They can help. This is a form of collaboration, and I think it's a good progress. In my own university here, there's a unit we call traditional medicine unit, which I coordinate, and I teach traditional medicine. And interestingly, I know it was a hidden unit. People are not really interested because of the stigma that is always attached to traditional medicine. But now we are rewriting the narrative. We are reconstructing the space and or the edifice, and we are having students who come to do a PhD, or do a master's degree in traditional medicine. Another success is the passing of traditional medicine into law, or traditional medicine bill into law. It's moving. Atlantis has got to the 3rd reading. I mean, somebody can please help to clarify this, and most likely by very soon it will be signed into law. And these are all tremendous progress that is going on in the field of indigenous knowledge and traditional medicine in Africa and also in Nigeria. The next line, please. Yeah, traditional medicine and disease treatment. Some of the so-called incurable disease that hospitals sees, death sentence, and some they say they cannot be managed. I say it's not true. It's not true. It's not true, sir. It's not true. Diabetes is curable. I had diabetes, and it's cured. I don't know, I think it's a methodological challenge. How those who do methodology in medicine, and use their methodology to get a result. Your methodology determines your result. The Western scientific laboratory methodology will not lead to results. But indigenous methodology will lead to results. I had diabetes, it is cured. And I went to hospitals, I was diagnosed, I used diabetes, I used drug drug. When I saw the drug killing me, I stopped it. And I went to my native drug. Now, diabetes, for example, let me shock you that Momodica Kirantia, that is aging, is able to manage diabetes effectively well. Just aging, I'm sure many of you know aging. I don't know the name in Igbo, but I know the name in English, Momodica Kirantia. Just get it and take it for maybe 1 month, 2, 3 months. It will help to regulate your sugar system. So also hypertension. Hypertension, I also say, is curable because people come to me for all these things, and they are all, in fact, they're cancer. I have not treated cancer, but I have a member who always come to our institute to teach us medicine. Yes, it's a bitter gout. Yes, bitter gout. Who come to teach us medicine? And it said, after I established the claim, he said unequivocally and very intensely and emphatically that he has cured many people with different kinds of cancer. Why I agree with him is that it's a question of methodology, like I earlier said. The Western man will use methodology not to get results, but in just man will use methodology to get results. If the Western man should come and use African methodology, they will get results, or he will get results. He said that they have treated many people with cancer of the breast, cancer of the pancreas, and all kinds of cancer. And he taught us medicine that could be used to manage cancer or to treat and cure cancer. He taught us more than 7 or 8 different kinds of recipe. And I also know how to know a particular medicine works. And in my own, critical analysis, I got to realize that these medicines are truly effective because of the kind of plants, bark, and root that he mentioned. These are the ways by which I would know this person is not any life. So hepatitis B, for example, with Amaranthus philanthus, what we call it, Amaranthus philanthus, with that particular plant only, just soaking it or steaming it and drinking it, I know it's not able to cure it absolutely, but it is able to manage it and suppress it so that you can still survive. And to cure it properly, if all this medicine, when you combine, this combinability is very essential in traditional medicine. Most of the people that work on, on a plant using Western, scientific methodology are always interested in one plant, aging, plantos, all this, just one plant. They search and search, get what they call active constituent, and they synthesize it. They package it, systematize it, and they say, no, you don't stop. Go. The bark, the root, the plant, the stem, even the latex. Even to cure malaria, we can combine up to 6, 7 plants for purpose of efficacy. That I think is the major difference between those who are doing phytomedical analysis and those of us who are just traditional medicine practitioner. We respect combinability, and the other one respects just one plant. The next line, please. Something took me to the first line, which okay. So Some of these, all diseases have been found to be curable. And traditional medicine is really advancing. The lesson learned is that the decolonization agenda is becoming a global agenda. And Africa is not taking advantage of decolonization. Europe is initiating decolonization, even decolonization of epistemology, decolonization of ontology. In fact, I'm working on decolonization of ontology, because the kind of reality that colonization creates in our intellect is different from reality that we find ourselves. We are not taking advantage of the decolonization agenda that is globally sold to us, even by Europe. And so this is the time to wake up and begin to advance the value of knowledge, particularly in knowledge, in the advancement of Africa and the advancement of the world. So part of the way we can undo colonization is to accept the value inherent in our indigenous knowledge. We will be decolonized. That indigenous knowledge will help to decolonize us. And the center to decolonization is African medicine. In fact, interestingly, your topic is about indigenous knowledge, but we are all talking about African medicine, which means that I don't know how much people can say about indigenous knowledge when they're not talking about traditional medicine. So traditional medicine is indigenous knowledge. Indigenous knowledge is traditional medicine for now. When I go to places to present paper, I've never seen people presenting stuff on indigenous knowledge without talking too poorly on traditional medicine. So the space is open for us. The world is now has now opened the door for us. That is the moment the world has opened its door for Africa. The whole world has opened its door for Africa. And we should now hold our space. We should just launch it and establish ourselves within the space so as to, see and, activate, demonstrate what Africa has to offer to humanity. The next slide, please. The next slide. Yeah. So I plead that we hold more programs like this. It's very, very important. In fact, it's good that many people are part of this project all over many parts of Africa and beyond. So we sensitize, mobilize, and make sure people's interest in traditional medicine. I am of the opinion that in line with Prof, that there should be a synergy of methodology. There's a methodological chasm. Unless we do a synergy of methodology, we may not advance. What Prof is doing, very interesting, but it's not. I can't do it, and I'm sure what I'm doing, he can't do it. But when I do what I'm doing, he does what we do, what he's doing, and we combine together, we will advance more. So we need to encourage well-formalized way of educating people about indigenous knowledge. And we should do self-reflection. We should be able to have an understanding of the extent of damage that colonization has done into our mindset. We cannot really do an objective assessment. Why? Because it has become the norms. It is becoming normative. It's now so normal. So that's why we think it is just, for example, I can assure you, and I'm saying it, that even speaking English too much is a disease. I'm sorry to say it. It's a sickness. Speaking English all the time. It's a terrible mental problem. We don't know this. Sometimes when we speak English too much, we think we are arrived. We are great people. That's the real problem. So there's the need for us to do a self-reflection. Even wearing English dress too much, all these things, British, all these things, Western, when it engulfs and envelopes us too much, it's a terrible mental problem. So tomorrow we can say that most of us in Africa are in terrible mental problem because our brain have been properly, reset and reset abnormally. So in that word, we should engage in critical recovery. We should reject whatever fosters colonization. We should reject it. We should say no. If it is coming from abroad, say no to this. We should ask ourselves, what is our forefathers saying? What about that question? How did our forefathers do it? What is the value of knowledge? 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 What is the val what is the way, whatever, even in sickness, malaria, how did our forefathers handle malaria? HIV/AIDS, that is the question we asked during COVID-19. We lost hope today in Western medicine. We look up to our forefathers and we succeeded. During war, we look up to our forefathers. Even in Boko Haram, it is not soldiers that are fighting Boko Haram effectively. It is the native, the hunters. So we have that, mindset to always go back to our origin and ask how they did it, and we employ it to solve our problem. What I call the wisdom of our forefathers. The next line, next line, sir. Yeah. Sorry, remove this thing. Remove something here. I want to see how I concluded it. Oh, something is blocking me here. Okay. In knowledge, African medicine, scientific medicine, and all those things we are talking about. The real problem of Africa is colonization. And that if Africa was not colonized, Africa would have been better off. Thank you very much for listening.
Thank you very much, Dr. Jegede. That very energetic and detailed presentation. I was just looking at the time. Our time is well spent. We're going to take, I think, only 1 or 2 questions. But before we take that, I can see somebody raising up his hand if he's still willing to speak. Eunice, indigenous knowledge. Can Secretariat allow him or her to speak? 2 hands raised up. Please be very straight, go straight to your contribution and your questions. We have just 2 minutes to contribute. Secretariat, please, can you allow them to unmute them and allow them to speak? The two participants are raising up their hands. Secretariat.
Please unmute yourself.
Please unmute yourself and speak. Introduce yourself and make your contribution as fast as possible. Hello, you can unmute yourself and speak. Secretariat has allowed you to speak. Okay, I think we should.
Good afternoon.
Yeah, good afternoon.
I'm very happy to be a part of this program today. I've been a part for a very long period of time. You can see from my comments, decolonization is one of the problems we are having in Africa, and we must be very careful. Now that we are awakening, people like Dr. Jegede, the other professor, they can take a lead and give us a avenue of collaborating with them in their researches. Somebody like me is very ready to learn. I've been here for about 6 months in India now. Indians have taken the lead. They celebrate their National Science Day on the 25th of February. My eyes was clearly opened when I listened to their scientists. It is a time for Africans to take the lead as well. I am of opinion that no nation will transfer their technology for us to survive. We have to rely on our indigenous technology. Otherwise, we cannot make it as a nation. Thank you so much. Dr. Jegede, I'm from UI Ibadan. When I come around, I will say hi to you. I will come and visit you. And I will take my time as well to communicate the other professor. GET, thank you so much for giving the opportunity. Thank you so much.
Thank you so much for joining this meeting. Thank you, our participants. Like I said, we'll share the details of our speakers so that collaborations can continue even after this meeting. The second speaker, please, the second participant, you can unmute and speak. You have just 2 minutes to contribute. Okay, I guess the second speaker is no more online or something is happening. Can see most of the questions have been answered by Prof. I can see Prof have answered most of the questions. Thank you, Prof, for answering most of the questions. Our time is well spent. We spent over 1 hour, 30 minutes on this platform. So I think, like I said, we're going to share the presentations of our speakers and their contacts so that we can continue collaborations even after this presentation. Let me round up by thanking our participants for being part of this very important webinar again. You are the only reason why we'll continue to organize this webinar. And our hope is that this webinar will be a very great platform for us to continue to discuss issues around infectious diseases, biosecurity, and One Health, and finding indigenous African-led solutions to African challenges. Before we go, I want to give the opportunity to Wanki Uwagi to speak for 2 minutes. Wanki, you can unmute and speak for 2 minutes before I round up the webinar for today. Please unmute yourself and speak.
Good afternoon or good morning, everybody, depending on wherever you are. I don't know if you can hear me, please.
Yes, we can. Go on with your
Okay.
contribution.
Yeah, thank you very much. I am talking from California, United States. And I'm pleased to inform the House that Professor Kenneth was my senior in secondary school and an early mentor. When he invited me to come here, and there was just no way I could resist being here. It's 4 a.m. I came here at 4 a.m. It's exactly 5:38 a.m. here in California. So I would like to say something. There was something that Dr. Jegede said that really triggered me. And I've had the opportunity to work for Afebalola University. I'm a professor of psychiatric mental health nursing. And currently I work as a board certified health and wellness coach and a mental health expert. So Dr. Jagede said something which was really intriguing about the current research that's taking place at University of Ibadan. You see, I think one of the issues or one of the challenges that we have back in Africa in terms of promoting traditional medicine is that we are nonchalant. I wouldn't sugarcoat it. I'll just say exactly as it is. We are nonchalant because we already, if you look at the phytochemistry, it's already existing. A lot of research has been carried out on this subject. Researchers will tell you, even, I don't know, bitter melon, Momodica charantia, the active ingredient in Momodica charantia is charantin. It is there. We just have to leverage this research, existing research, leverage what happens in our community. As we know, like Prof was saying, it has to be an integrated approach. Because for these medications or for this medicine to be standardized, it has to be integrative. It must be integrative. So if we are not combining it with the science, how do we get these products licensed? How do we get these products recognized? How do we get these products to be used? How do we even arrive at a dosage? How do we even conduct a toxicology analysis? How do we get a toxicology report on it when we do not integrate science into it? It is very, very important. So I think some of the methodologies that we might want to consider would be research and documentation, and then quality control and standardization. That's very important. And integration with modern medicine, education and training, regulation and legal recognition, community engagement and cultural preservation, Afrocentricity. Prof keeps talking about Afrocentricity. We cannot do this without preserving our culture, And the way we do things in Africa, it's a little different. So this aspect must be integrated. And then promoting sustainable practices. And of course, public awareness. Because public awareness will allow for better acceptance. Thank you. That's my contribution.
Thank you very much, Doc. And with that contribution, we're coming close to the end of the webinar today, but we cannot end this webinar without thanking our presenters, Professor Kenneth and Dr. Jegede, for those very wonderful presentations. I personally have gained so much from your presentations, and I strongly believe this is the beginning of collaboration between my organization and presenters. There's so much we can do together, and hopefully we'll continue discussion after this presentation. So thank you very much, Professor Kenneth and Dr. Jegede, and congratulations to the wonderful work you're doing in preserving our indigenous knowledge and solving health issues in Africa. Like I said, we're going to share their presentations and their contacts with our participants, because I'm very sure there's a lot of our participants who want to get to learn more and ask more questions from them. Also, I want to say a very big thank you for those that have stayed with us in the last 1.5 hours. Thank you, our participants, for joining this webinar again this month. You are the reason why we continue to do this every month. We appreciate you. I will say thank you. We look forward to seeing you this time next month by God's grace. Also, we also share a certificate of participant with all our participants. You'll get your certificate within the next 2 days as a token to say thank you for being part of this webinar every month. We are going to continue this webinar next month with another very interesting topic in the area of OneNet and biosecurity, and we look forward to talking to you and bringing experts to talk about emerging issues again this time next month. Until then, thank you very much, our participants, and thank you to our speakers. Have a lovely rest of the day, and bye to everybody. Bye-bye.
Thank you.